Welcome to this episode of Let's Talk, where we zoom in on the practical applications and the next steps after this Milan Congress session, the opening plenary actually, about the challenge of multiple missing teeth in the aesthetic zone. My name is Gerrit Heijkoop and I'm very happy and proud to be joined by the chairs of that plenary one session. Massimo Simion from Italy, welcome.
Hi, thank you.
Glad to have you here. And also Irena Sailer from Switzerland, welcome.
Thank you very much. We're happy to be here.
Exactly. You just literally walked off stage, still glowing a little bit from that first plenary session. Let's start with the basics. Why in a EAO Congress 2024 we put in our first plenary session the topic of multiple missing teeth in the aesthetic zone, Massimo?
Yeah, that's a good question, because it's the nightmare of all the reconstructive dentistry, the prosthodontists and the surgeons, because when you have to deal with just one tooth in aesthetic areas, you have usually the anatomy which is there, so it's not easy, but it's something...
You have a reference.
You have a reference. But when you have multiple teeth and you have a flat ridge or you have some defects, then it's very difficult to go back to the, to the previous anatomy and to give that back the patient kind of a restitutio ad integrum with everything like was before. That's the most difficult part of our job.
Irena?
And specifically if the patients have a high smile line, so that they really expose everything and they really would like to have a natural appearance of the teeth, supported by the implants, which has to have also a natural appearance of the soft tissues, the surrounding ones. And if many teeth are missing, the soft tissues are rather flat, so everything has to be created, recreated, and then supported by the prosthesis, and that's very challenging. It takes a lot of time.
So first of all, because we're in the aesthetic zone, also then multiple teeth missing. Just as a very basic reference, what would you say that is the incidence of this happening? Like, do you see this quite a lot? Does it depend on where you work? What would you, or is this the exemption?
Depends, I think, on your specialization. For example, it happens a lot to me because usually those very difficult patients are referred by dentists because they don't know how to manage them. So I receive quite a lot of patients like this.
Exactly.
And because they know that I treat this kind of patients.
Exactly. So it's definitely high-level dentistry that we're talking about. Irena, do you see them a lot?
Well, we are university clinics, so we get always the difficult and complicated cases. And I think so also we see maybe more than normally in the daily private practice you would see. But it's definitely not the easy cases that we see in most of the situations.
Exactly. So you're the very fit chairs for this session. Let's see if we dive in. If we look after this session, what are some of the changes that the speakers are trying to evoke here in the audience? What are some things we need to start doing in the clinic?
Yes, what is, I would say, new as a trend from a therapeutical point of view, is that in the past we were considering much more the hard tissue, the bone, to regenerate bone, regenerate bone, regenerate bone. And we were considering, but not so much, the importance of the soft tissues. Today there is a trend to consider soft tissues at least as the same kind of rate of importance than the hard tissues. So in all these cases of aesthetic areas, we do bone regeneration and soft tissue augmentation. And then there are different, trends. Some are regenerating more bone and a little bit less soft tissues. Other ones are regenerating no bone and a lot of soft tissue. So
exactly, but in general, adding the soft tissue as a key topic is a key novelty that we start to talk about here in this Congress. If I look at your three different speakers, you also took it from a surgical versus a prosthetic management perspective. What is the key challenge or message there?
Well, the message is, I think, that you have to make a lot of efforts on the surgical side to have sufficient soft tissues and a lot of effort on the prosthetic side to shape these soft tissues to have these restorations appear natural. But we've also, and something that we've not discussed that much in this session, was an alternative treatment to all the surgery is to replace the missing tissues with the pink porcelain part. And that's something which specific cases with maybe not the highest smile line can also be a good option and would reduce the invasiveness of the treatment. I know the surgeons don't like it, and he hates it, he already told me.
So maybe we can turn this Let's Talk into a primary debate, but let's follow up and understand, because you're a professor in prosthodontics, so I can assume, I know this is possible, innovation, skip the surgery and let's fix it with prosthodontics if the case allows, like you say.
If the case allows.
If the smile line covers some of the soft tissue anyway. Why, Massimo, do you immediately cringe and say no?
I did probably once or twice in my life in the cases in which I had the failures, and so
Failing implants or failing teeth?
failing surgeries. So I was not able to regenerate enough bone or enough soft tissue, so the patient didn't want to do again the surgery because it was too much. And so the only thing you can do is to make a fake porcelain, but it's not something that I do routinely, even because I think my patient will be not happy at all. They will complain.
Why?
Because also, even though you can obtain very nice aesthetical result, you need a very good technician to mimic, the colors and the texture of the, the natural mucosa around. But even if you have that, from a psychological point of view, for the patient to have this kind of prosthesis in a single or multiple,
especially in multiple missing teeth,
If you have a total edentulous patient, it's okay.
Yeah.
We do that. We kind of call them Toronto bridges or something like that, and this is accepted. But if you have natural teeth with natural gums, and then you have a fake gingiva in an area, in the frontal area, the patient, they don't like it. They go to the
because they lift up the smile and they see still the missing soft tissue. Right? So, Irena, you bring it on this Let's Talk table. You want to talk about it. So apparently you see promising results nevertheless. How do those patients react to this drawback that Massimo is bringing up?
I'm totally agreeing with Massimo.
So you agree
in
with
this
that part?
Absolutely. Yeah. It's very challenging. You need a very skilled dental technician because it's not just one ceramic pink powder. It's many that they need to mimic the natural appearance of soft tissues, and then also the surface texture is very important. And if the transition of the pink porcelain to the natural gingiva is somewhere in the visible area, patients will not accept it.
Exactly.
And that's clear. That's why these full arch cases are ideal, because they have nothing to compare it with. And it's.
But then I challenge you again, because you just brought the topic to the table. So there must be something promising there.
There is promising, absolutely. I would say in some surgeries, some clinical situations, it is an alternative to these multiple invasive surgeries in specific patient cases, because you can just, avoid all of this and replace the tissues with porcelain.
And specific cases is always a very black box in this Congress. So what type of cases would be eligible for these kind of solutions?
Well, first of all, it's a patient request. That's, I think, the most important part. And then it's also the visibility of the area, so that smile line height.
Yeah.
With a patient that doesn't expose it, it may be a very good option. Patients that expose it, it's not an option.
And when you say it's on patient request, I guess you take away your biggest obstacle for this, because now the patient actually says, I want this.
The patient you treat with this kind of techniques, with multiple surgeries, they are 25 years old, very beautiful girls.
Well, somehow that always seems to be the cases in these congresses.
That's when he gets referred.
Yeah, exactly.
I don't get
and
that
often
referred.
Also getting married somewhere in the next 9 months.
Exactly. For example, the live surgery we are doing tomorrow is a model that had a terrible car crash, and he had a defect that arrived to the base of the nose, losing 3 incisors. And we did last year surgery, and tomorrow we will do the connective tissue graft, the implants. But the typical is young people, mainly girls, but also young.
Could age be a differentiator? For example, for the and I'll stop on the pink prosthetic anyway. But I can imagine in a much older patient, they are easier accepting such a thing than someone who has to live with this for 50, 60, 70 years?
Probably yes. But I would also, in the young patients, I would consider those with medical compromise situations.
Absolutely.
Where you want to avoid multiple surgeries, also as eligible patients for this maybe less attractive type of version.
Okay. So we kind of went into the rabbit hole of the pink ceramic solutions. Let's step out and go back to these multiple missing teeth and the challenges there. You mentioned the new focus on the managing the soft tissue. We heard more about that in this Let's Talk table as well. What is some of the novelties that came across in your plenary session?
I think what also was really nicely stressed is how important the planning is. The prosthetic planning in the beginning, and then the surgical planning according to the prosthetic goal, and then all the respective steps may be easier and guided by three-dimensional digital technologies that allow for a nicer planning, maybe less invasive even, surgical procedures, and a more predictable outcome in the end, because everybody in the team knew as of the beginning what we're aiming for. And I think this is also something that all three speakers nicely stressed, how much they use the new technologies to have more predictable outcomes.
Just to understand what these technologies enable, is it correct then, because if you say what's new is this integral planning, right, from the visualization, and before did the surgeon just put the implant in and the prosthetics could fix it?
Well, it did happen like this, I have to admit.
Does the surgeon agree with that?
Not in Massimo's practice.
No, but that was what happened in the early days of osseointegration, like 30, 35 years ago. You see the picture, the X-ray, there is bone, put an implant, and you try to place it in the right position. But we have seen cases terribly restored because the implant were. And but then later on, we started to place the implant in a prosthetically guided situation, not with digital, but with the diagnostic walk-in models, diagnostic walk-in, and with the stent, plastic stent
exactly.
were made, and with the holes to guide the burr. So it was something similar to what we do today, but in a very
two-dimensional way.
More analog way, exactly. No, because I'm surprised, and I want to reiterate the message if the message needs to be told, but I'm relatively surprised that in our plenary session, one of the key takeaways is we need a more interdisciplinary planning process, right? So apparently, in some places in this field, it's still throwing the implant over the wall.
Well, they don't say we need more, but they stress the importance of we need this. We should do this. They recommend absolutely a good planning ahead of the plan, ahead of all the interventions, and a good communication with the team and specifically with the patient. So you define with the diagnostics the goal in the beginning, the patient approves, and then you can plan the treatment phases and steps accordingly.
And mainly in the positioning of the implant in accordance with the prosthesis. In the regeneration of bone and soft tissues, as a plan, you can have information, you can guess, okay, I need this, but you cannot really precisely say, okay, I need 5 millimeters of bone and 3.5 millimeters or 4 millimeters of soft tissues, because then the surgery and the healing is a different story.
There's variety there, right?
Variety.
It's not a robot, and the human being is also not
and
robotic.
Nobody heals like the other one, so you can just guess, okay, I need this, and so you try to get that point.
But you can use the technology to be also more personalized in this type of perspective. You can design the graft on the screen in 3 dimensions and then have it produced as a prefabricated regeneration piece that resembles exactly the defect that you want to heal or fill in. On the same also for soft tissues. I think this
like meshes or membranes you can prepare before. Using a model with the reconstruction of the bone that you want to obtain, and then you create your instrument so it's ready to be placed in the right...
On top of it, specifically in the aesthetic zone. Now finally, if we hear these messages, and especially the soft tissue message seem to be echoing through this Congress, what is the biggest challenge that we need to overcome in the clinic to make this a reality? Because we can say it here in this Congress, but how do we prevent us from next year having the same conversation?
I think from a surgical point of view, the biggest challenge is first that the dentists, if they are not used to be surgeons, are afraid to take big pieces of connective tissue from the palate, because when you take the piece of connective tissue, you have bleeding.
Exactly.
And if you are not used to see bleeding, you get a little
Yeah,
bit.
it's tricky. Yeah, I can imagine that you get
Yeah.
uncomfortable.
Yes.
That's
Yeah.
the first. And the second criticism is that, like we said also during the session, when you do bone augmentation, usually you don't have big pain. You have swelling, but you don't have big pain in the mouth of the patient. When you do this kind of collection of the harvesting of connective tissues, the patient has pain for 15 days. And some patients say, yes, I have pain. Other patients said, oh, I had the worst 15 days of my life.
Yeah.
Because it's very subjective, very different from a patient to the other one, and from the thickness of the connective tissue that you take. So patients don't like it.
No.
Exactly.
They don't like
Well,
it.
that's a wonderful new insight, because I've been hearing this, soft tissue, and I wonder, why don't we do it? But this is very clear. It's very invasive for the patient, uncomfortable.
Yeah.
Do they know up front that this is going to happen? Like, is this a conversation that we have in the chair where you say, well, I can make your aesthetic outcome better, but you will be in pain for 2 weeks?
Yeah. I think you can do easily also several times in the patient that have big motivations, patient that have big aesthetical problems, mainly young patient is, a businessman 60 years old doesn't care about aesthetics. You have some of them.
Careful what you say, but maybe less, a little bit less. Yeah.
But young patients, younger that want to be able to smile, and they are ready to be treated with everything for
So patient
years.
motivation is a key factor
is a key
when you
factor,
deal with the soft tissue management.
If a patient is not motivated, I don't treat him with this kind of
with this type of procedure.
procedure.
Irena, what is that for you? What do you see is the biggest challenge that we need to overcome in the clinic to not have this conversation again next year?
The amount of soft tissues that is available as well is very limited, because you have both sides of the palate. You maybe have the areas behind the last molars, but in principle that's it. And once harvested, you have to wait until it regrows if you want to augment again. So that's also
And
something.
the regrowth is never
as before.
much as before.
Yeah.
Okay, so we are hopefully waiting for alternative materials there.
Substitute materials that are available, but the documentation yet is not
They
as
are available,
convincing.
but they're not as good.
Yeah.
Exactly. You're spoiling one of the Is It True segments that we are also creating in this one. If you're watching all of the stuff we have here in Milan Online, you already know the answer to this one. Yeah. So promising result, but not there yet.
Yeah.
Clear. Massimo, Irene, thank you very much for having this little debrief after your plenary one. And I can imagine you're super curious to go watch this session in the Milan Online Library. The three speakers were Anne Benhamou from France, Luca De Stavoli from Italy, and Carlo Monaco, also from Italy. So go out there, go educate yourself based on science.